Good afternoon, and thank you for joining us today for Banyan's Fall Prevention webinar. My name is Eric Preisler, and I will be your moderator today. This is a pre-recorded webinar from one of our previous in our Fall Prevention series. Our main speaker today will be Linda Rittermeyer, who we will introduce shortly. We do have one CEU credit, which is available for full completion of this webinar. To receive this, we do require that you stay on for the duration of the webinar and complete the survey, which we will be sending out after the webinar. Before we begin, I'd like to go over some housekeeping items. First and foremost, I'll have everybody unmute their computer speakers. If you can hear me right now, we're off to a pretty good start. On the right side of your screen there, you'll see a question box. Feel free to type into that question box any of your questions or comments. Because this is a pre-recording, we will not touch on any of them as we go, but we will have a live interactive Q&A session with myself and Linda at the end, where we will get to any questions that you've submitted. During the webinar, we will have polling questions. These are completely confidential and will not show any individual answer, but we will show our group as a whole and the percentages on how we answered some of those questions. Also on the right, during our interactive Q&A, you'll see a little hand being raised. Now that hand will raise your hand to us, and we will actually unmute your line at that point, and you can ask any question or have any comments live. I would now like to go over our agenda we have for you today. I'm going to start out by introducing Linda Rittermeyer, our main speaker for the day. And she's going to go into falls, the reality in healthcare. So what we're all seeing every day, the problems that we're dealing with, this is not just an individual site problem. This is happening all across the country. So she's going to touch on what we're seeing. Then we're going to go into fall prevention best practices. What are people doing around the country? What does Joint Commission say we should be doing? We're going to talk about all of that. Then we're going to have Jeff Brose, our Vice President of Innovation here at Banyan, talk about one hospital's journey. And that hospital is CHI Emmanuel, and he's going to go into how we built a falls program with them and some of the results that we've seen with that. And then we're going to end with our live interactive Q&A, where you'll be able to raise your hand and have any comments or questions directed at us, or you can also use the chat box on the side to type any questions you may have. I would like to introduce our main presenter today. Linda Rittermeyer is our Vice President of Clinical Operations here at Banyan Medical Systems, and she is a former CNO from the HCA Health System. So without any further ado, Linda.
Good afternoon, everybody, and thank you for joining us. Today we're going to look and talk about falls. So as we all know, falls remains a huge issue. In our hospitals, and 1 million people who fall in our hospitals every year. Out of that, up to 50% of those falls result in injuries. And we also know that the cost of those falls are upwards of about $23,000. Length of stay is increased by 6.3 days per fall. That's quite an increase in your length of stay, especially when we're trying to decrease our length of stay. And here's a statistic that I found pretty amazing. 26% of all our patients who fall were not identified as a fall risk at the initial assessment.
So Linda, it looks like we have a question that just got submitted. So Jessica asked, what is the national average of falls per patient days in hospitals, as I'd like to know where I compare with the average?
So according to CMS, the average is 4.3 falls. So we'll talk about that a little bit more, and I think that we'll be able to see where everybody falls. But yep, that's the answer.
All right, so this brings us to our first live polling question. So again, this is going to be completely confidential, and we will share our results as a whole here. But the question is, what is your estimated falls per 1,000 patient days? 0 to 2, 3 to 5, 6 to 8, 9 to 10, or 10 plus. So we'll give you about 20 or 30 seconds here to answer this, and then we'll go over the results and get back into the webinar. So it looks like we have pretty good response here so far. A lot of you are sitting right in that national average, around 36 to 40% of you are in that 3 to 5 range, which is about what we would expect. A few of you are sitting a little bit higher. Just a few more seconds here. Looks like about 65% of people have voted so far, so we'll give you a few more seconds and then we'll close the poll down. All right, perfect. We got about 70% response here. We'll go ahead and share those results. So it looks like most of the people on this webinar here are sitting right in that 3 to 5 range, which is right at the national average. We do have a few people that are sitting over 10, which is probably a reason why we're all here today. You know, we're looking to bring those numbers down. So this was just to give us an idea of where we're all sitting, and we'll turn it back over to Linda now.
So as our highest risk units, as would be concluded, rehab units usually have the highest fall rate. So statistically, it's, our statistics show that 7.15 falls per patient day in a rehab unit. Most of us don't have rehab units in our hospitals, so let's look at med-surg. 3.92 falls per 1,000 patient beds in a med-surg unit. And here's the one that surprised me the most, ICUs. So in our ICUs, our patients are cared for either 1-to-1, 2-to-1. Eyes are always on our ICU patients. There's still 1.3 falls per 1,000 patient beds. Personally, I just found that a pretty amazing statistic. So according to Leapfrog, again, I've been a nurse for over 30 years. I know that we've talked about falls most of my nursing career. And Leapfrog shows their results with 65% of responding hospitals still do not meet the standard for hacks and falls. So falls are still an issue. 2017, these statistics are from Leapfrog. Here we are in 2018, and we're still talking about falls. I just think that there's an opportunity. What can we really do to stop falls? So for me, it's not only the statistics, and it's not only what happens. We talked a little bit about what the cost was for the hospital. There's a personal cost to our patients, but then also what's the cost to our nurses? Our nurses feel horrible when they have a fall. I know when I've done a post-fall huddle, my nurses are pretty torn up about falls. So there's got to be a solution that we can find that will help our nurses, our patients, and our hospital. And trying to staff our falls, you know, contracted pools, 1-to-1 sitters, those are all great. And we're going to go over a study here in just a minute. But the cost of those sitters is disproportionately high. And then sometimes we have to pull our RN to go in and to sit in as sitters, leaving their responsibilities at the bedside. Other peers are picking up those responsibilities. I don't know about you, but my staff was not happy if they had to pull, and neither were their peers. So best practices, what do we use today? What does it look like? So all the different strategies, and I'm sure that a lot of you have tried these. You know, we do the fall risk assessment, and on a previous slide, if you remember, 26% of our patients still are not identified as a fall risk. We all have the yellow wristbands, the yellow footies, the door markers, you know, falling stars, falling leaves, whatever you use at your hospital, hourly rounding. Personally, I can't tell you how many times I made signs, posted signs for the patient and their family, call, don't fall. I'm sure some of you even have them on your that saying on your whiteboard. And then we all do our post-fall debriefing. And then we have alarms. We have our bed alarms and chair alarms. Usually those alarms, by the time they go off, it's a little bit too late. because the patient's already moved off of that alarm. Or those alarms continue to go off because you have to turn up the sensitivity that when the patient's just turning in bed, the alarm's going off. So that leads us to alarm fatigue. There's a lot of stuff included in this. So I'm going to tell you a personal story. My father-in-law was in the hospital a few years back, and he was in there for confusion. Knowing what happens in hospitals, been in many hospitals, and I even knew some of the nurses that worked in this hospital, we've tried to come up with a personalized plan for him. So our family took shifts. We were there from about 6 o'clock in the morning till about 10 o'clock at night. We all shared that time. At night, he had a one-to-one sitter. He had the yellow band. He had the yellow booties on, you know, the falling stars. He was on a bed alarm, all the different things that we worked together to put together his personalized plan so he would not fall. So in the middle of an afternoon, my brother-in-law was sitting with my father-in-law, and he was asleep. My father-in-law was asleep. Well, my brother-in-law thought it was a good time that he could go get a cup of coffee because he still had a couple hours left on his shift. And with my father-in-law sleeping, he didn't have the TV or anything to keep him awake. So he got up. Coffee pot was just right down the hall. He went down the hall to go get his coffee, turned around, was coming back, and lo and behold, there goes an alarm. Yep, it was my father-in-law. Him and the nurse hit the door about the same amount of time, and he was on the floor. They had to send him downstairs from x-rays. He was complaining about some pain. They took him downstairs, did some x-rays, and he had some cracked ribs. Longer length of stay in the hospital, all the things that happen post-fall. The poor nurse, she was totally distraught because she was 100% sure, as we were, that we had done everything we could to keep him from falling. So it just shows that even with sitters, even though that's the answer, sometimes unless the eyes are on the patient all the time, we want zero or near zero falls. So we really have to find other ways to make sure that we hone in on that. The problem with some of our programs is that there's not enough coverage. The falls have already happened, alarm fatigue. So what works? So yes, fall sitters do work, and many hospitals do have their sitter program, but at what results? The results are the cost. That's where it really gets shifted.
All right, so this brings us to our second polling question for the day. Again, completely confidential here, and we'll give you about 30 or 40 seconds to go ahead and answer this. But this is kind of a general overview of do you currently have a sitter program, a physical sitter program, or virtual, or do you not use any sitter program? So we'll give you guys a few seconds here to answer this and just kind of get an idea from the group on what everybody's looked at, what everybody's been doing. So looks like we have about 60% of people have answered so far, and it looks like most people are using physical sitters, which is kind of what we've seen from these webinars in the past and from kind of surveys from across the nation. We'll just give you a few more seconds here. We have about 75% of the people who voted, and then we'll share those results with you live. Looks like we're staying right at about 50% of people are currently using physical sitters, and then about 40% are do not have any type of sitter right now. So we'll go ahead and close the poll here, and we'll share with you the results. So this is pretty much what we've seen across the country when we've done these type of surveys. So about 50% of people are using physical sitters, and again, as Linda was talking about, it's pretty pricey to use those physical sitters. Looks like some of you have been looking at a virtual sitter program, which is fantastic. It's a great way to have all the benefits of the physical sitters while lowering the costs that are associated with those. Some people are using both, which usually people who we've seen have implemented virtual sitters will use physical sitters as well to supplement for certain types of patients that need that one-on-one contact inside the room. and about 40%, just under 40%, have not looked at either. So this might be a pretty good learning experience to see the benefits of physical sitters and virtual sitters, and show some of the cost savings involved with that. So we'll go ahead and turn it back over to Linda.
So I have a great study that I want to share with everybody. So there was a study done back in 2014, over 18 months, 75 hospitals were included that were in Pennsylvania. Their study was pretty phenomenal. They showed that over their 18-month collection of data, the patients that did not have sitters that fell was almost 54,000. Pretty significant. When you compare that to the number of patients who fell that had monitored with sitters, was only 323. I say only 323 because it's a smaller number, although all of us would like to have no falls during that time. Falls with injuries, there was a little bit over 1,600 per room with no sitters, only 11 in the rooms where there were sitters. So again, pretty good statistics, not the zero that we always are looking for, but good statistics, amazing results. But then what is the cost of those one-to-one sitters? One hospital within the study incurred an annual expense of about $500,000. Very effective, but it would be hard for me to take that number to my board or to my CFO to justify that cost for one-to-one sitters. So some hospitals are starting to look at virtual sitters, which is a more cost-effective way and better for the patient. So I'm going to share just a little bit of what it looks like here at Banyan. So Banyan, we have one-to-one sitters that are effective, but they aren't as expensive. Banyan has created a virtual sitter solution that enables the value of the sitters to prevent falls, but at less than 20% of the cost. As you can see in this slide, Banyan's fall prevention platform includes a sitter station, allowing the sitter to visualize 1 to 15 patients in their ratio. Up to 15 patients, that's a pretty good ratio. Patient rooms are equipped with a camera, the two-way speaker, and the virtual sitters are connected to your bedside staff to enable an effective and affordable sitter solution. This solution has been proven to significantly reduce falls and falls with injury. So I'm going to touch on some key points here that I had just mentioned. 1 to 15 based on acuity. I'm going to point out that this isn't for every patient. We know that we're still going to we realize that there's still going to be some patients. You'll have suicide patients that still need to be within arm's reach and those types of stuff. So we're not going to 100% take away patients, but you'll see some pretty amazing statistics later in the presentation. The sitter station has that workflow communication tool, again, keeping your staff and the sitter connected for the patient's safety. The camera and the two-way speaker. So I think the two-way speaker is really a piece that really is proactive instead of reactive to what's going on with your patient. So let's say I'm your patient in bed. I forget that I'm in the hospital. It's the middle of the night. I want to get up to go to the restroom. I'm squirming around in the bed. The sitter can say, "Hey, Mrs. Rittermeyer, it looks like you're moving around. Can I help you with something?" "Yeah, I need to get up and go to the restroom." "Hold on 1 second. We're going to have somebody in there to help you." So I really do think that two-way communication is critical, plus the communication with your staff.
So now we're going to turn it over to Jeff Brose, who is our Vice President of Innovation here at Banyan Medical Systems. And he's going to talk about one hospital's journey and a case study and pilot that we ran with the virtual sitters at their facility.
normally. CHI Health is a 15 hospital region that sits right here in the heart of Nebraska and a little bit in western Iowa, and they have about 350 short-term acute care beds, and they have a connected spine hospital that has some interesting patient populations that go into it as well. They're a certified stroke center and a pathway to excellence designation. And they have a world-class heart program as well. So she's got a pretty neat little spot up there in the northern part of Omaha, and quite a population of patients. They also, she didn't really toot her own horn here enough, but they have a very incredible rehab program, which we're going to talk a little bit about here shortly. So what we did a couple of years ago with her is they wanted to do, their safety officer wanted to do an initial pilot. And they'd never done anything with virtual monitoring before. They did use a whole bunch of one-to-one sitters with their patient population, and they still were having a falls problem. They were up in the 6+ range. Well, what happened was they purchased 55 cameras, and they spread those 55 cameras across multiple units. So I'll give you the drum roll here and give you these results, so don't fall out of your chair. Go ahead. So on the results, their sitter usage went down 13%, and their change in falls was basically inconclusive. Now, don't hang up. The point is that we learned a big lesson here with pilots and success stories. They have to have focus. So go ahead, Anthony, hit the next. So when you take too many strands of data, so they were looking at too many things, number one. They were looking at not just falls, but like, let's just lump it all together and call it safety across all of these different units. And to be clear, it was obviously a subset of these units. This first rollout of 55 only contained, for example, 12 of their rehab beds. They had maybe 10 cameras up on a med-surg floor and so on. And it was very, very difficult to stratify and then quantify those findings so we could trend. They had a lot of near-miss incidents, so they knew that they were getting their eyes on more patients, which was great, and they knew there was a benefit here, but they didn't exactly have the ability to empirically quantify it because of the way their data was stratified. There was also a natural tendency for scope creep. So if you step back and think about this for a second, you've now got a camera in a space that you've never been able to really see into unless you physically walked in there, right? Or if you're peeking through the window or something. And what happened was their staff saw this as an opportunity to do a whole bunch of stuff. Falls, sure, falls was easy to monitor, but how about hand hygiene for their staff? So we had an issue in the first couple of days of this pilot where a nurse was reporting another nurse for not washing their hands. Okay, that missed the target. So I want you to understand that when you do these rollouts and when we go through this evaluation process with you, it's going to be tight. If you want to use it for other things down the road, that's perfect, but you need to be able to have a really solid data set and data that you can trend on a particular indication before you do your pilot. And it will snowball. I'll promise you that when you roll out a virtual sitter program, you're going to be using it for a plethora of things, but you need to wait until you've gotten your fall target achieved, and then you can move on from there. So what we did then is we went back to the drawing board and did another pilot that was more focused. And this was all in about a 6-month time frame, okay? We created a tighter focus, and we finished the rest of the rehab unit. So there were 35 beds that were in that basically brand new unit. It was beautiful. 12 of them already had cameras from the initial pilot, so we finished the others. And then we looked at very specific fall-related data, and we did something a little bit different, and we used the existing nurse call system to communicate with the patient instead of using a speaker mic in those rooms. And this is only important to say because they just rolled out at that time the Responder 5 system from Rollin, and they had what they called a very sophisticated base station already in the falls area. So they could literally hot dial a patient room and say, Mr. Smith, looks like you're trying to get out of bed. Are you okay? And have that conversation through nurse call rather than going through the speaker mic solution in the ceiling. So that was an interesting thing. We tightened up the results then, and we were able to look at what we were going to measure and then come out with very empirical data. So in terms of one-to-one sitter reduction, they hit it out of the park. They decreased that utilization 84%, and at a savings of 165,000. That's a big saving. The cost per patient hour watch decreased $20. So you take it down 92%. If you think about the number of sitters you're using, and you can take 92% of that cost out per patient hour, that is a significant savings without a doubt. The falls with injury decreased 75%, save almost $500,000. This does not even include the litigation or any of subsequent procedures and things like that had to be done. If that patient had to go to surgery and have a drain put in or something like that, this number is without that. This is with just treating the injury itself in the acute sense. And then the overall fall rate decreased about 22%, which was statistically significant. That's a mouthful. So these pilot results were the type of results that Catherine and team were expecting to get with that 55-bed initial pilot, but they didn't have the ducks in a row. We collectively, we'll take ownership too, didn't have our ducks in a row to get them that empirical data quickly. So it was pretty significant. Just to summarize it a little bit differently and show you the Indian QI benchmarks and where they fell pre and post, they were their baseline fall rate was about 6.3, and they took it down to about 4.9 in this period of time, and they had a 75% improvement of injuries, which we already mentioned, and then that huge reduction in one-to-one sitters. So if you look at the costs and the quality impact to this, that's definitely number one, two of the three of the triple aim. And then we have to add in the staff satisfaction, which will add another one, because the staff now on the floor felt so much better because the bedside nurses knew that this patient was able to be directed and totally fine, but they were also able or willing to take their movement into their own hands and get up and go to the bathroom when they shouldn't. And so having that extra set of eyes was a huge satisfier for them in this pilot. So that kind of runs through what we saw in that amount of time. And again, we'll share Catherine's contact information with all of you so that you know that, and we'll set her up that she's going to get bombarded, but we'll allow you to ask her direct questions so that we're not putting words in her mouth. She created those slides and results, so we're just being the messenger right now, and appreciate your understanding of that. So the next thing we have is looking at some of the questions that we've had submitted in our chat, and while some of those are still coming in, please continue to. There's quite a few, so please continue to submit those. We'll address a couple of them here. Do we have any data regarding senior behavioral health units or dementia units? I know that there is data. Data for falls down to the unit and patient level is incredibly difficult to find. It's funny, we can get the global number from CMS and Indian QI and so forth, but it's really hard to say, patients with these conditions, what is their fall rate? We do not have specific data on that very pointed behavioral health unit. However, I will say the advisory board, I believe, has got some data that we're happy to follow up with you with. To share what we can find with it. So when we send out our follow-up email, we'll try to include whatever information we can regarding that level of specificity. Let me pick out a couple more here. We want to be sensitive to your time. If clinical staff is experiencing alarm fatigue, what is the benefit of virtual alarms? So that's the point that we want to hammer home here. We're not alarming. It's important to understand from a workflow perspective that we're not saying that the nurse is sitting there, the virtual sitter is sitting there, and they are seeing a behavior change with the patient, and then they're relaying that through some sort of alarm to somebody else. In fact, that would be almost worthless, to be honest. It's too long of a time for patients who are agile and are going to get out of bed. So what we do from a workflow perspective is during your admission process, I'll just kind of take you through the quick visit. Through the admissions process, the Falls program is now introduced by Catherine's team as a standard of care. There's no separate consent or anything necessary because you've got no recording, and we're not an educational facility in this case, so there's no need to consent to recording and things like that. And the patient understands if they have been deemed a fall risk and they're going to be watched through the camera or if they're not. And that conversation, honestly, and Catherine will attest to this with her vast experience, it's pretty simple to have. You'd think that there'd be more pushback than there is, and that just has not been what we've experienced at any of our facilities, much less just Catherine's.
To give you a little bit more information about who we are as Banyan, we are currently in 36% of the top health systems in the United States. And you can see on your screen now, these are some of our partner facilities which we work with. All right, so now we're going to get into the live Q&A session with myself and Linda Rittermeyer. We've had quite a few questions come in, so we'll try to touch on all of them in about the next 20 to 30 minutes or so. And please feel free to raise your hand again at any time, and we can unmute your line and get any comments or questions that you have going forward. So the first question here we have was directed towards Linda. And so she said, I've heard of a Falls cart system. So what is the difference between an in-room virtual monitoring sitter compared to a cart system?
Thanks, Eric. So we don't use a cart system for some very specific reasons. One, introducing a cart system, the plug itself, you're bringing in a trip hazard just by having it plugged in. Patients, family can touch that cart, so sometimes you'll lose that full view of the room, so that kind of puts your patient back at a possibility of a fall. And then the ethical question is, let's say you have 8 patients that need to be monitored. You only have 6 carts. So ethically, who doesn't get the cart to watch them? The cart system is very expensive. And those are just a few reasons off the top of my head. While I believe that with our system having that two-way communication, it's up in the ceiling, it's cleaned when the room is cleaned. I mean, these carts have to be taken in and out, making sure that they're cleaned properly and that type of thing. There's not an increase in infection rates or anything with our system being up into the ceiling. So those are just a few reasons off the top of my head that I can see where there's a difference between having a cart system and the virtual system that we have.
Perfect. Thank you, Linda. Looks like our next question here, Christine asked, what about psychiatric beds? Where do they fall on the continuum nationally? So as Jeff had mentioned, it's hard to get down to that unit base number, but I can tell you that NDNQI, their benchmark for geriatric site unit is 14.8. So for the same reasons that we can show an improvement in any unit, there will be an improvement using our system. But right now, that's the NDNQI rating for falls per 1,000 patient days. Okay, and what about in psychiatric units? How would these be used in a psychiatric unit?
So the same way that we would use it any other way, we're monitoring the patients.
It's also the safety of your staff. I know Jeff talked about, very focused that we're watching falls, but you also have the safety of your staff to consider. Patients that maybe have a little bit of a different diagnosis, you might still use those one-to-one sitters on an extreme patient, but you can use those virtual sitters to monitor your patients, to redirect them, to decrease on your falls. So you can use it for that piece. And then, like I said, for the safety of your staff, to make sure if anything's happening, when somebody's in a room, you can get help in there immediately.
All right, so our next question coming in here from Jessica. How is it decided which patients are monitored and which ones aren't with a system like this?
So that decision wouldn't have to be there. You could monitor all your patients. If you put this in every patient room, and as I pointed out before, 26% of patients weren't even realized to be a fall risk upon admission. So there's not the decision or the ethical decision of who gets watched or whatever. All you have to do is flip that camera on in that room, and that patient's being monitored. So again, it's not limited by how many, like I pointed out with the carts, you have this camera in every room that can, and all those patients can be watched.
Perfect. We have quite a few more questions coming in here on the chat box here. And also remember, you can hit that hand icon on the right side of your screen there if you'd like to put your 2 cents in and comment or ask a question directly to Linda. So it looks like our next question coming in here is from Deborah. So how does this technology work with the position statement from the Joint Commission?
So great question. Joint Commission just came out with a statement saying that, of course, now I'm not pointing out our within arm's reach patients, but patients can be monitored with a virtual sitter. It was in their position statement that came out in November 2017 is when that statement came out, and they here, I think, if I'm not mistaken, because I thought, so what Joint Commission says is patients with a serious suicidal ideation must be placed under reliable monitoring, an observation allowing 360-degree viewing, which we do with continuous monitoring video. So while we don't record anything, we don't save anything, we fall within the report of what Joint Commission has suggested for monitoring. So that will free up one-to-one sitters, give you a little bit more flexibility, and the ability that maybe your arms reach patients, depending on what your population is, that you're able to make sure that your arms reach patients, suicidal patients, are covered with your one-to-one sitters.
All right, perfect. Our next question here is coming in from Tammy. So Linda, what about the privacy of the patient? And can the camera be turned on and off for bathing, toileting, etc.?
So again, a great question. While the nurse is in the patient's room, that communication between the virtual sitter and the nurse, so the nurse can be in the room, or whomever, it doesn't have to be the nurse, can say, hey, could you please shut off the camera for Mrs. Rittermeyer? I'm going to give her a bath. Or, hey, we're going to get up out of the bed. I'm going to be here with her. I'm going to get her up to the bathroom. That camera can be shut off through that communication, and then when say the bathing is done or whatever, all they have to do is say, hey, will you turn this camera back on, so that they can communicate back and forth and make sure that happens. Let's say the nurse forgets, the bedside care team forgets to say something to the the sitter, they know that bath probably should have only taken, whatever it is, 5 minutes. So they can always check with the nurse and say, hey, can I turn this camera back on? Are you done? That way your patients aren't left unattended.
Perfect. Our next question we have here on the list, Cindy asks, does the virtual sitter engage with the floor staff to get help for the patient if needed? And if so, how do they do that interaction?
So yes, the sitter does engage the floor staff to get in there, and it's however you communicate today. I know a lot of hospitals that I've been in use Voicera or something like that. So whatever that communication is, they can immediately contact the staff. Let's say in our example that we used earlier, I'm laying in the bed, I'm fidgeting around. While that virtual sitter is speaking to me to be proactive, they're already contacting the nurse or the care assistant or whomever to please go in there and check with me. So they almost happen simultaneously, which is where we can say that it's proactive as opposed to reactive. So that communication, we don't change the way that you communicate. We just enhance the way that communication. And depending if it needs to be some tweaks here and there, we can always help you with that too.
Yep, absolutely. And just to expand on that as well, our workflow tool, you can annotate and you can draw pictures on the screen. So if there is a plane that they don't cross, the second they look like they're about to cross that, we can actually contact the nurse's station before we even contact the patient. And like Linda said, a lot of times it'll happen simultaneously, but it's really nice to get that nursing staff alerted as quickly as possible. And with a system like the one that we have, we really have designed it to make sure that the nurses are staying informed, that are able to, be proactive, and instead of by the time they get it in there, their patient's on the floor. So moving on to our next question here. So Linda, who trains the virtual sitter?
So Banyan can help train that virtual sitter. We have a whole program together. So I believe Eric had mentioned when we come in and we work with you to get this program put together, we're partnering with you. We don't just come in and install the program and say, have fun and hope you decrease your falls. We're there with you step by step. We help train those nurses. We help to make sure that the flow is correct with that workflow management system that Eric mentioned. We make sure that all of that is in place. So we not only help train that virtual nurse, but we also help to train the staff on the other side to utilize the system and make sure that communication is streamlined, again, to make sure that the patients aren't falling.
Perfect. Another question we have here is, would we still need to do a patient risk assessment using your system?
So I would say whatever your policy says would be the way that you would go. There's a lot of systems out there. I don't know, which ones any of you use, but I'm sure we're probably pretty familiar with the Morris Fall scale, the Hendrick scale, the Stratify scale. So it depends on what you use, because you want to know where your higher acuity patients are. But since you're putting everybody, so that 26% that you're capturing, so you want to know, your patients that are if it's let's just say if it's a 1 to 5 point system, let's just say that you want to make sure that your 4s and 5s are your high acuity, but your 3s and 2s and 3s might still be that 26% that falls. So in this way, you would want to do your assessment so that when we're training your sitters, we can say, here's your high acuity patients, and then here's your other patients. Do they change the way that they take care of their care? No, not at all. But it is also that higher acuity patient is on their workflow management tool, that they know that this patient is a higher acuity patient. So I would say that you would still use your tool. If you use a tool now and it's in your policy, you're going to have to change your policy. So it depends on how the hospital themselves, we can work with the hospital to make sure that we follow Joint Commission, we follow CMS, that we're doing all the proper checking the boxes. But those different fall tools, I think, will still come in handy when that patient's admitted, so that you know where your acuity stands.
Yeah, absolutely. Very well said, Linda. It looks like Christine here has another question for us. Do hospitals have their virtual sitter station on the unit, or is it a centralized station for multiple units?
So we suggest that you don't put the sitter area on the unit. It's too easy for somebody to come in and say, can you just help me move this patient for 2 seconds? Well, if your virtual sitter is watching, let's say, 15 to 20 of your patients, that means you've left those patients unattended. So what we suggest is that it's in a centrally located area. We have hospitals. If you just think of it as kind of like a tele type usage, that a lot of the tele-monitor offices are away from the units. So same type of thought process. And depending on the size of your unit and the acuity, yes, that virtual sitter can watch patients across various units. But again, that's going to depend on your size of your unit, the acuity of your patients, and what the hospital themselves decide is the bandwidth of that sitter. Can they watch, maybe you can watch 20 patients that are a level 2 on your acuity scale, but they only want them to watch 10 patients maybe with a higher acuity. So again, that workflow process and how that looks is something that we're able to help you with in the beginning to get that hardwired and how that looks.
Perfect. Thanks, Linda. And just to add to that a little bit, with our system in particular, we have had partners who will have a centralized sitter station watching multiple floors at a time. And again, like Linda said, it goes back to your facility's preference, what you want to do. Training programs are different depending on policies and procedures that you have. But efficiency is kind of the name of the game right now. And so if we can find a way to have a sitter monitor multiple units, and that is the most effective and safest way, best way to treat your patients, then absolutely that's how we should do it. And the system kind of gets molded to that philosophy. All right, it looks like we have our last question here in the box for now. And so Cindy asks, they currently use bed and chair alarms, and it works fairly well, and they're seeing pretty good results. So how would this add to it, and how is this better how is this better than just the regular alarms?
So again, great question. And I believe that we talked about this a little bit in the presentation, that those bed alarms, I'm going to use my personal story that I interjected. So a lot of times that's reactive as opposed to proactive. Those patients, when that bed alarm goes off or the chair alarm, they've already slidden down to the floor. our staff, they hear those alarms, and let's say they're close enough that they can go in there. I mean, I can't tell you how many of my staff have tweaked their backs by trying to keep that patient from hitting the floor, so it doesn't count as a fall. The cost of the bed alarms themselves, I mean, all the pads and everything else that you have to buy to take care of all that, it just gets to be very consuming with the alarms, not to talk about the alarm fatigue itself. It's like sometimes, that you have so many alarms going off between the IV pump and all the other monitors that can do any kind of bells or whistles. Your staff sometimes becomes a little numb to those alarms, so that can always be a problem. We don't have an alarm with our system. It's that conversation, that one-to-one talking to each other. So the alarm fatigue doesn't happen in this situation. So I think that the bed alarms, while great, they're working for your hospital, and you've seen a decrease in falls. I believe that having this more proactive system is really where it's looking for. There is a study that I'm going to bring up here. It is a study that was done by a Dr. Shore. It's titled, you can look it up, it's Effects of an Intervention to Increase Bed Alarm Use to Prevent Falls in Hospitalized Patients, a cluster randomization trial. And when they ran their study, they actually did not see the data to say that bed alarms or chair alarms decreased falls by any amount. So while you may see a little bit of a difference, I'm not sure that it's something that's going to be prolonged, and it may be just a temporary fix to decrease your falls.
All right, thank you, Linda. So just to wrap up a little bit, it looks like the questions are starting to slow down a little bit. Our contact information is right there on the slide, so if anything else comes to mind, if you wake up in a sweat in the middle of the night and have another burning question, feel free to reach out to Linda or myself at any time. We'll be happy to talk to you one-on-one to answer any questions you have via email. We do have a few more events that we're going to be sponsoring or attending coming up in the next couple months. So we have a readmission prevention webinar that we're going to be hosting on October the 18th. So we would encourage all of you to jump on that webinar. We're going to go over some best practices and talk a little bit more about virtual technology and how it can be used in a readmission prevention strategy and philosophy. We are also going to be attending the Magnet Conference in Denver, Colorado on October the 24th through the 26th. We're going to be in booth number 1375, so we'd love for you to stop by and come visit us if you guys are going to be out there for that. We have gotten quite a few questions on if the slides are going to be made available for this presentation. So following up this, within the next about 24 hours, we will be sending out an email which will have a link to the recording of the presentation as well as a PDF of the slides that we presented here today. We also have our CEU credit that was available for your attendance. So be sure to fill out the survey that we send out after this webinar. And as soon as we receive that you've filled out the survey, then we will send you back your CEU credit and we'll be all good there. So thank you all very much for attending today. We had a wonderful turnout and we hope to speak to all of you soon. Have a great rest of your day.